Hello, today we are going to discuss the variation and distribution of fluid and electrolytes in different body compartments, and we are going to discuss both physiological variation and pathological variations, especially in different surgical states, different pathological states, especially in surgical patients or in traumatic patients. And we are going to focus major on how the fluids, electrolytes, and other chemical compositions of body fluids occur following these above mentioned cases. Our learning outline today will majorly focus on the normal distribution of body fluids, that is physiologically. Then we shall also discuss about the chemical composition of body fluids in different compartments. We shall also discuss the daily water balance and exchange in a normal human being, followed by disturbances in fluid volumes, disturbances in electrolytes and acid-base balance, and disturbances in acid-base balance. An average male who is 70 kg comprises of 55 to 60% of body weight as total body water, and a similar female who is 70 kg has 45 to 60% of total body weight as her total body water. And it should be noted that females have lower total body water than males because females have a higher fat content than males. The total body water in neonates, on the other hand, is 80 to 85% of their total body weight, and should be remembered that mild losses or even diarrhea could cause adverse effects or adverse harm on a neonate compared to an adult. Why? Because much of the body weight or much of the body composition neonates is water, and so slight losses could have adverse effects on the body of a neonate. The body water, the total body water, is distributed into two major compartments of the body. That is the intracellular fluid and the extracellular fluid. The intracellular fluid, which is a larger compartment, takes 2/3 of the total body weight, while the extracellular fluid takes 1/3 of the total body weight. Water distribution in the extracellular fluid. It should be noted that the extracellular fluid is further divided into two other compartments, which are the intravascular compartment and the interstitial compartment. The intravascular compartment, which is also known as plasma, comprises of 2/3 of the extracellular fluid, while the interstitial compartment comprises 1/3 of the extracellular fluid. As we have just finished discussing on how total body water is distributed in different body compartments, likewise, electrolytes vary in different body compartments, and we are going to discuss in detail the chemical composition of body fluid in different compartments. And we shall majorly focus on 3 major compartments, which is the intravascular compartment, which is the largest, and then the extravascular compartment or extracellular space or extracellular fluid, which is composed of the intracellular and interstitial fluid, as we have seen. So it should be further noted that the interstitial fluid, which is the extracellular fluid, is composed of 143, as you can see, 143 millimoles of potassium compared to the intracellular compartment, which has only 8. So therefore, the interstitial compartment has a higher concentration of sodium than the intracellular compartment, meaning that the extracellular fluid is always having a higher concentration of sodium, and on the other hand, the intracellular fluid is always having a higher concentration of potassium. And these variations are very critical and important in the normal functioning of cells, that is impulse transmission, They are also important in the exchange of metabolites like glucose absorption, intake, and in and out of the cell. And so any alteration in deviations in these two major cations, that is potassium and sodium, could have adverse effects on the metabolic functioning of the cell. To repeat myself, I would like to insist that the body water is distributed majorly into two major compartments, and that is the intravascular compartment and the intravascular compartment and the extravascular compartment. And the extravascular compartment is further divided into the intracellular and interstitial space, as we had discussed in the slides that we just finished. But it is important to note that the intracellular compartment is always having higher concentration of potassium, while the interstitial or extracellular fluid is always having a higher concentration of sodium. On an average day, our body loses water through various mechanisms, that is through urine, which is 1,500 ml. There are also insensible losses in form of breath, sweat, which is always between 1,000 and 1,700 ml, and then stool, that is 200 ml. And so in total, the total output or the total fluid losses in our bodies are always between 2,700 to 3,400 ml per day. And our intakes are either through oral intakes and from metabolism. And so much of the water is always obtained from oral intake, which is through fluids we take, the food we eat. Water drained from them is always between 2,500 to 3,200 ml. And another form of water is always generated from metabolism, that is oxidation, and it is always approximately 2,000 ml. So generally, our net requirement is always between 2,500 to 3,200 ml to replace or to maintain the normal functioning of our bodies. A minimum urinary output of 400 ml is always required per day to excrete waste products of metabolism. And commonly available replacement fluids in case of fluid losses that are clinically used to replace the fluid deficits or the fluid abnormalities are normal saline, Ringer's lactate, and glucose 5%. And our first replacement fluid discussed in detail is normal saline, which has sodium, which is 154 millimole per liter, chloride, which is 154 millimole per liter, and normal saline does not have potassium. As you can observe, it has almost 0 millimole per liter of potassium and almost 0 millimole per liter of carbohydrate. And therefore, normal saline is always preferred in replacement of blood loss and extracellular fluid loss. As you had discussed in the previous slide, the potassium is always an intracellular fluid cation. Potassium is an intracellular fluid cation, while sodium is an extracellular fluid cation. So normal saline having a high concentration of sodium and chloride is always preferred in replacing extracellular fluid losses, since much of extracellular fluid is having high levels of sodium. Normal saline is always preferred in case one is experiencing excessive extracellular fluid losses. On the other hand, Hartmann's solution has 131 millimole per liter of sodium, 112 millimole of chloride, and potassium 5 millimole. You observe that unlike normal saline, Ringer's lactate or Hartmann's solution has some concentration of potassium and is always preferred in replacement of blood loss and intracellular fluid losses, since, as we had discussed before, potassium is majorly an intracellular compartment cation. Glucose, on the other hand, has little to no sodium, chloride, and potassium, and has a high concentration of carbohydrate, which is 50 grams per liter, and is always used in maintenance and medication. All those are the commonly used replacement fluids. We are going to discuss now on common disturbances in body fluid and electrolyte distribution in different body compartments, and there are major three disturbances. That could be a disturbance in volume, a disturbance in electrolytes, and a disturbance in pH. Disturbances in volumes can either volume deficit or volume overload. Disturbance in electrolytes could be increased or reduced given electrolyte concentration, or a pH could be acidic or basic baseline or basic pH that could also cause altered function or distribution in different compartments. So our first discussion point is a disturbance in fluid volume, and we are going to discuss first volume deficit. Volume deficits are always secondary to loss of body fluids and electrolytes, and it could be secondary to acute blood loss, could be secondary to acute fluid loss in severe burns. So all those could cause volume deficit. So major causes include vomiting, gastric tube, diarrhea, and fistulas. Or there could be secondary sequestration in severe burns, such as burn patients, or in patients who are having infections, and for example in patients who are undergoing septic shock syndrome. You could also have excessive fluid sequestration, and you even having volume deficits. Other causes of volume deficit could be intra-abdominal or retroperitoneal inflammatory processes such as peritonitis and intestinal obstruction. Patients with volume deficits present with sleepiness and orthostatic hypertension in cases of moderate volume deficits, and in severe volume deficits, a patient may present with signs of hypotension. The patient may be comatose. They may have sunken eyeballs, dry mucous membranes. The skin turgor may be very poor, and then there's always their body temperature is always low, or they may have cold extremities. How do we treat volume deficits? As we had discussed earlier, we repress. In case the patient is having blood loss, you repress with Ringer's lactate or normal saline, but as you do such, you book for blood. Or in case the blood is readily available, you immediately transfuse the patient with blood, replace the lost blood volumes. And in case there is extracellular fluid losses, for example in severe burns or infection, you press with Ringer's lactate and normal salines so that to expand the plasma volume. The rate of fluid replacement in this case depends on the degree of dehydration, and you should, as you replace the fluid, you should do it fast until you observe that clinically the vital signs of the patient have improved. And the most reliable vital sign to use to assess for proper replacement and of lost fluids is through assessment of the urinary output, and the minimum or the optimum target for urinary output while administering replacement fluids is always 0.5 ml per kg per hour. So you assess and you estimate, and it is always good to assess and follow up on urine output through insertion of a urinary catheter in case the patient is an adult. But in neonates, you can still monitor minus inserting a urinary catheter. If a neonate is able to pass out urine, you can estimate. So the urine output that is above 0.5 ml per kg per hour is an indicator that your replacement fluids are working very well, and the renal system has not yet been injured by the volume deficit. But if it is low or less than 0.5, it means that you are at risk of causing acute renal failure, and you should either increase on volume on fluid replacement, or you should be more aggressive in order to save the patient's renal system or the patient's kidney. On the other hand, volume excess or volume overload can be caused by a number of factors, and some of them are iatrogenic, or they are medically induced. This could be secondary to excessive administration of intravenous fluids. Volume excess can be caused by renal insufficiency or renal failure. It could be caused by liver cirrhosis or a patient with congestive heart failure. All these could cause volume excesses, and patients with volume excesses present with edema, that is subcutaneous edema. Some of them have bacillars, that is on auscultation of the lung bases. Then there is always some patients present with distension of peripheral veins. Auscultation may also reveal murmurs. And treatment of volume excess or fluid overload is always you first stop the administration of IV fluids in case you've been doing so, and you give diuretics, for example, furosemide, to facilitate in the excretion of the excess fluids. From there, we're going to discuss about various disturbances in electrolytes, different electrolytes in the body, and how they can be collected. And our first important electrolyte is sodium, and as we had discussed earlier, sodium is an extracellular cation. And depression or decrease in serum sodium is also known as hyponatremia, and is clinically diagnosed when the serum sodium levels are less than 1 centimeter equivalent per liter. And hyponatremia may be associated with volume depression or volume intoxication. Hyponatremia, second to volume depression, could be due to excessive loss of water and alongside sodium that could cause a decreased serum sodium levels. And in this case, it occurs in cases of small intestinal obstruction or high output fistulas, for example, in the intestinal fistulas that could cause excessive fluid losses alongside sodium losses. And on the other hand, water intoxication could cause dilutional hyponatremia, and in this case, this is always seconded administration of IV, for example, D5%, or even in cases of colorectal washouts with plain water, which could all cause excessive absorption of body fluids that could, in the other hand, result in dilution of the serum sodium levels, causing dilutional hyponatremia. Patients with hyponatremia clinically present with signs and symptoms of the underlying cause. For example, if a patient is having hyponatremia secondary to volume excess or volume overload, they will be having clinical symptoms of volume overload, and on assessment you may find that the patient is also having hyponatremia, or else they may be having signs and symptoms of volume deficit, that is dehydration, shock, alongside the signs and symptoms of hyponatremia. And clinical investigation, you will reveal the serum levels of sodium less than 1 centimeter equivalent per liter, and in most cases the hematocrit is always low or less than 30% in patients with hyponatremia. Hyponatremia treatment is through administration of Ringer's lactate or normal saline in case of volume depression, or you can also, in case that is secondary to volume intoxication or fluid excess, you can stop administration of fluids and you give sodium sparing diuretics to help in retaining of sodium and help reverse the hyponatremia. On the other hand, hyponatremia is clinically diagnosed when the serum sodium levels are more than 145 millimole per liter, and is caused by numerous clinical conditions. However, the commonest causes may include excessive water loss in burns, sweating, or insensible losses through breathing. It can also be caused by excessive administration of 0.9% saline in early preoperative period, as this is associated with intraoperative period is always associated with excessive secretion of sodium, which is always secondary to impaired physiological functioning of the normal sodium potassium pump. So administration of IVs plus 0.9 saline or isotonic saline may result in hyponatremia post-operatively. So treatment of hyponatremia is through slow infusion of 5% dextrose. It should be noted that Following trauma and surgery, there is always a period of shutdown of the sodium excretion, and this always lasts 48 hours. And in this period, when there is shutdown in sodium excretion, it is not advisable to administer large quantities of isotonic saline. Why? Because there is impaired secretion and you may end up having hypernatremia, secondary to accumulation of serum sodium levels. The daily requirement of sodium is always 1 millimole per kg, and it should be noted that sodium is mostly abundant in the extracellular space. Our next important serum cation is potassium, and depletion in potassium levels, also known as hypokalemia, is clinically diagnosed when less than 3.5 millimole of serum potassium are assessed for and discovered. And causes of hypokalemia could be second to increased losses, that is through the gastrointestinal tract, that is maybe through vomiting. It may also be to gastric outlet obstruction that would also cause vomiting, or it could also be diarrhea. All these cause excessive secretion of cations and alongside body fluids, and you end up having hypokalemia. In other causes of hypokalemia can include alkalosis, that causes excessive movement in influx of potassium ions into the cells. In more so prolonged administration of fluids that do not contain potassium, that is maybe orally giving non-potassium containing oral fluids, could also cause hypokalemia, especially in patients who are having excessive or obligatory renal loss of potassium. Excessive renal excretion, e.g. in the use of diuretics, could also result in hypokalemia. Clinical features of hypokalemia may include slurred speech, listlessness. However, most patients are always asymptomatic, and when you examine these patients, most of them are hypotonic. They have hyporeflexia, and abdominal distension may be observed in cases of paralytic ileus. This is especially in surgical patients who are having abdominal distension. It could be due to paralytic ileus. More so, it should be important that you should, as a physician, distinguish between hypokalemia and lower motor neuron lesion, because both of them clinically on assessment, they have almost similar signs, because lower motor neuron lesion also presents with hypotonia. They also present with hyporeflexia. So this is also one of the differentials for lower motor neuron lesion, and it is important you assess for the serum potassium levels before you can conclude. Treatment of hypokalemia is through encouraging oral potassium intake, that is through milk, meat, fruit juices, honey, and you can also give potassium chloride tablets. Other oral sources of potassium can also be Irish potatoes, yellow bananas. In addition, you can also give intravenous potassium chloride, that is 40 millimole, and you add it to 1 liter of IV fluids, and you run over 6 to 8 hours. And it is advisable never to give potassium chloride intravenous directly. You first mix it with an IV fluid, and then you infuse it over 6 to 8 hours. And in addition to the above treatment and interventions, you should treat the underlying cause of hypokalemia. It is also important, as you manage and you repress or treat the hypokalemia, you should continuously monitor the urine output, and you should also continuously assess for the serum potassium levels to avoid progression into hypokalemia. On the other hand, hypokalemia is clinically diagnosed when the serum potassium levels are more than 5 millimole, and large amounts of intracellular potassium is released into the extracellular space in response to severe injury, surgery, acidosis, and catabolic states. Remember, potassium is majorly an intracellular compartment cation, and in cases of injury, surgery, and acidosis, there is injury to the cells, and as a result, there is always impaired mechanisms of the sodium-potassium pump, and you end up having excessive secretion of sodium, sort of potassium into the extracellular space, and you end up having hyperkalemia. In other cases, hyperkalemia may also be secondary to renal failure, and that in cases it could be oliguric or anuric renal failure. Hyperkalemia can also result from hypoaldosteronism that is always accompanied with renal failure. Patients with hypokalemia presents clinically with nausea, vomiting, they have intestinal colic, diarrhea, arrhythmias, and cardiac arrest, and cardiography in patients with hyperkalemia may also reveal high-peaked T waves, widened Chara S complex, depressed ST segment, and disappearance of T waves. As we are going to see, you can observe that in hyperkalemia we are having depressed ST segment. As you can observe, there is a high-peaked T wave. There is a widened Chara complex. You can also, there's a flat P wave. So you can compare. This is a normal ECG for a patient with normal serum potassium levels, and this is for a patient with hyperkalemia, and this is for a patient with hyperkalemia. You can compare and contrast the differences, and this can also help you in diagnosing a patient with hyperkalemia. Treatment of hyperkalemia is through administration of glucose, insulin alongside bicarbonate, and we always give 10-20 units of regular insulin and alongside 25 to 50 grams of glucose. Or else, alternatively, you can also give 10 ml of 10% calcium gluconate. You can also give kayexerate. And this is always important in enhancing cation exchange. You can also do dialysis, and this one is always the final intervention to reduce and remove the excess serum potassium levels, and this is always preferred in cases when the kidney has completely failed, or patients with chronic kidney disease and patients with acute renal failure, and you observe that the patient is having refractory hyperkalemia, they are not responding to treatment. Dialysis is always the last resort mode of treatment. And as you do all the above mentioned interventions, it is advisable to avoid all the exogenous potassium, that is dietary potassium sources like dietary feeds that have high concentration of potassium, as we had earlier discussed, that is protein, that is fruits, honey, Irish potatoes. They should be avoided until the required potassium serum levels have been attained. On a daily basis, the average daily requirement of potassium is always 1 millimole per kg, and it should be memorized that potassium is always an intracellular compartment cation, and most of it is always found in the skeletal muscles. Let's now discuss on our next cation, which is calcium. The normal serum calcium levels are always between 8.5 to 10.5 milligrams per deciliter, and pH variation has effect on the concentration or the serum distribution of calcium, as an increase in pH causes a decrease in the cation or an ionized form of calcium, and this is therefore understandable that in metabolic alkalosis you could end up also having hypocalcemia secondary to a decreased serum ions of calcium. Hypocalcemia is clinically defined when the serum calcium levels are below 8 milligrams per deciliter. And common causes of hypocalcemia could be hypoparathyroidism after thyroid surgery, and in this case, it is always secondary to accidental injury or accidental removal of hypoparathyroid glands. Remember, the parathyroid glands are always in close proximity with the thyroid gland. So in surgery, there could be accidental injury or removal of these parathyroid glands, and you end up having hypoparathyroidism. Other causes of hypocalcemia could acute pancreatitis. There is also massive soft tissue infections such as necrotizing fasciitis, pancreatic and small bowel fistulas. All these could cause hypocalcemia. Clinically, clinical features of hypocalcemia include muscle spasms, paresthesias, anxiety, seizures, among others. There could also be cardiomyopathies, Chevostek's sign, as we're going to discuss in the slides to come. All these are some of the clinical features of hypocalcemia. Hypocalcemia clinically presents as in two forms, that is latent hypocalcemia and symptomatic hypocalcemia. Latent hypocalcemia presents with two clinical signs, which include positive Chevostek sign and Trussell sign. On the other hand, symptomatic hypocalcemia may also present with numbness and tingling, hyperactive tendon reflexes, muscle and abdominal cramp, tetany with capital spasms, and convulsions. What is Chevostek sign? Chevostek sign is one of the clinical findings in a patient with hypocalcemia, and it is a feature of tetany. It refers to an abnormal reaction to the stimulation of the facial nerve. So when the facial nerve is tapped at the angle of the jaw, that is the masseter muscle, the facial muscle on the same side of the face will contract momentarily due to hyperexcitability of the nerve. As you can see in the illustration, tapping on the masseter muscle causes contraction of the facial muscles on the same side of the face, and this is always secondary to hyperactivity of one of the branches of the facial nerve. On the other hand, Trussell sign, this is a involuntary contraction of the muscles in the hand and wrist, that is the carpal pedal spasm that occurs after compression of the upper arm with the blood pressure cuff, as you can see in the illustration. That is the Trussell sign. Blood pressure cuff is inflated and to generate pressure, and when pressure is generated for 2 to 3 minutes, then you have positive Trussell sign, which is always shown with flexion at the wrist, thumb, metacarpopharyngeal joints, and extension of fingers. Treatment of hypocalcemia is through administration of intravenous calcium gluconate, that is 10 mils of 10% calcium gluconate over 10 minutes, or you can also administer calcium chloride. You can also give oral calcium lactate alongside vitamin D to help in management of hypocalcemia. Remember, vitamin D is always important in absorption of calcium from gastrointestinal tract. Hypercalcemia is clinically diagnosed when the serum calcium levels exceed 10.5 milligrams per deciliter, and it's always associated with hyperparathyroidism, vitamin D intoxication, cancer, and prolonged immobilization. Clinical features of hypercalcemia may include fatigue, lassitude, weakness of varying degree, anorexia, nausea, vomiting, among others, but it should be noted that most patients with hypercalcemia are asymptomatic. Treatment of hypercalcemia, a rise in serum calcium levels, a level above 15 milligrams per deciliter, is always treated as a medical emergency, and it is managed through vigorous volume repression with salt solutions, that is IV fluids, and also administration of IV or oral phosphate or mithramycin. So now we are going to discuss about acid-base balance. The body pH, normal body pH is between 7.35, 7.45, and metabolic alkalosis is when the body pH is above 7.45, and it is always caused by loss of acid from the stomach. That is maybe through increased vomiting or aspiration. It can also be caused by excessive ingestion of an alkali, absorbable alkali. It can also be caused by hypokalemic, by pyrolic stenosis, where you find the patient is having a constricted pyrolic sphincter, and then they are excessively vomiting, and the vomiting process, they are vomiting a lot of acids, and in addition to that, they are also vomiting potassium, and this case is called hypokalemic alkalosis. And patients with metabolic alkalosis present with chain stop breathing, with periods of apnea, and they may also present with tetany. Treatment of metabolic alkalosis, it is through administration of fluids, that is IV fluids, to replenish the lost volumes in the cases of vomiting. Then in addition to that, it is advisable to administer potassium to replace the lost potassium ions, and as you do so, you administer for the urine output. In the cases of resistant metabolic alkalosis, it is advisable to give 0.1 to 0.2 newtons of hydrochloric acid in case of resistant metabolic alkalosis. On the other hand, respiratory alkalosis is when the partial pressures of carbon dioxide are below 31 milligrams of mercury, and it is also caused by excessive ventilation, especially in patients undergoing anesthesia. Excessive ventilation can also be due to severe pain. Hyperreflexia can also cause respiratory alkalosis. Encephalitis and high altitude, all these can cause respiratory alkalosis. Patients with respiratory alkalosis present clinically with ventricular arrhythmias and fibrillation, and these are related to potassium depression. Treatment is through breathing into a plastic bag and insufflation with carbon dioxide. Metabolic acidosis, it should be noted that breathing in a plastic bag allows the patient to inhale his or her own excreted carbon dioxide, and you're trying to treat the respiratory alkalosis. On the other hand, metabolic acidosis is caused by increased fixed acids in saturation, and most of these increased fixed acids are always secondary to anaerobic tissue metabolism, for example in shock or infection or tissue injury. It can also be secondary to retention of metabolites in renal insufficiency. Somebody is having acute renal failure or chronic kidney disease, and they are not able to excrete these excessive metabolites and acids. The patient ends up in metabolic acidosis. And then there's also formation of ketone bodies in diabetic patients, or even patients who are starving. People are starving, it could also end up causing metabolic acidosis. Or else, other causes of metabolic acidosis due to secondary losses of alkalis or bases, for example in patients with long-standing or chronic diarrhea, or in patients who are having high intestinal fistulas. Patients with metabolic acidosis present clinically with signs and symptoms of the primary cause. If the patient is having shock, the patient is having excessive vomiting, if the patient is having high output fistulas, they have signs and symptoms of the initial cause of the primary cause. And in addition to that, they may present with rapid deep noisy breathing, and their urine pH is extremely acidic. Treatment of metabolic acidosis is through reperfusion, that is through administration of IV fluids to treat the tissue hypoxia. You give oxygen, and in addition to that, You may give sodium bicarbonate in cases excessive bases have been lost. Respiratory acidosis, on the other hand, is caused by impaired alveolar function. And causes of impaired alveolar function may include airway obstruction, thoracic and upper abdominal incisions, pneumonia, atelectasis, especially in postoperative patients, inadequate ventilation in anesthetized patients. Clinical features of respiratory acidosis include restlessness, hypertension, tachycardia, and hypercapnia. And respiratory acidosis is treated through, first of all, treating the underlying cause. Maybe it could, what is causing poor alveolar ventilation. If it is airway obstruction, you treat it. If it is atelectasis, you treat it. If it is pneumonia, you treat it. And in addition to that, you give supportive treatment through treating the complication. Maybe you relieve the airway obstruction, you give analgesia in case severe pain which is causing poor ventilation. You also give drainage in case it is maybe pleural effusion. You can also do intubation and mechanical ventilation, and this is always done in severe cases of respiratory acidosis. Thank you for tuning in and listening. See you soon. I hope this sharing benefits both of us.